All right, can we still see the slides?
I can't. This is Cindy.
Cindy, I'll email them to you.
So I can see them.
Everybody besides Cindy can see them?
I can.
Yeah.
Yes.
Yes, I can.
Floor is yours.
So much. Well, good evening, everyone. My name is Dr. Phil Mangaluso. I'm with Pulse for Pulse. With me is Christine Tyrell, who's our new business development, Sam Mitchell, who's our director of implementation, and we're here to talk to you about what we do so well in the microvascular space. So I'll take you through a little bit of the next 11 slides. It won't be very long, but just to impress upon you what we do and why it's so very important, not only as clinicians to address, but more important for our patient population. I always start off by saying I went to Creighton Med School back in 1994 to 1998. The number one cause of death back then was cardiovascular disease. Going back 7.5 decades when my mom was born in 1948, cardiovascular disease. Fast forward to when my children were born in 97, 99, and 2003, cardiovascular disease. 2025, number one cause of death, cardiovascular disease. And that is despite all of the incredible inventions, etc., processes, new medications, statin drugs, the Jardiances of the world, the Kerendias of the world. And the reason why I say that is because we've missed the mark with cardiovascular disease. When you think about where I was at Creighton, it took us 5 days to put someone on telemetry, watch the liver test invert to see if they actually had an MI, right? Unless if there was a T wave change on the EKG. Now we have door to cath times of 90 minutes or less. And while we're saving more people, cardiovascular disease still remains the number one cause of death. And the reason is simple. Oh, no, it's not.
I got it.
So I'll talk, maybe we can advance the slide. I'll talk and we'll catch up the slides. So here's the important thing to know about cardiovascular disease. Right? We have 60,000 miles of blood vessels in our body. 15% of those blood vessels are large blood vessels. The other 85% are small blood vessels. And so when you think about that, and the fact that we tailor all of our processes and our protocols towards large blood vessels, it's no wonder that we're missing the mark. And so what we do really well at Pulse is we identify the 15% of the small blood vessels. Now the 85% of the small blood vessels. Now we do one test that will look at the 15%, but our protocol is a 3-test protocol that looks at both ABI, pseudomotor testing, and autonomic nervous system testing. And I'll go over that again in a second. Here's the slide that I really want to take some time and tell you why it's so important. When I was at Creighton, we were taught, okay, we're going to treat events that are in the orange and in the red. The end stage events, right? End stage heart disease, cardiovascular disease, changes at the level of the heart, left atrial enlargement, left ventricular hypertrophy, brain changes, right? TIAs and strokes. Really, we should be concentrating on the green and the yellow where endothelial dysfunction starts. That's where the money is, in my opinion, from a standpoint of really identifying and helping patients through the process. And our testing that I mentioned earlier will look at some of those indices in a very intimate way in terms of identifying small blood vessel disease, things like C2 that you can find in the literature, the ejection elasticity index, like product augmentation index, all look for stiffness of the small blood vessels. So what we do well at Pulse, and what I do in my own medical practice for the last 25 years, and maybe the last 15, is look at that green and yellow. I'm looking for small blood vessel disease in my population so that I can treat more aggressively. It's not enough to know that my patient is a vasculopath and they may have diabetes, they may have hypertension, they may have high cholesterol, which automatically qualifies them as a vascular incident waiting to happen. What's more important is for me to identify endothelial dysfunction, because we all know that cholesterol is not the main cause of heart attacks or strokes. It's certainly something that is present, but it's the inflammatory cascade that causes a heart attack or stroke. And so we spend a large amount of time in the small blood vessel disease arena. I mentioned earlier, so we're looking at a couple of tests that are small blood vessel disease and one that's large blood vessel. The ABI has stood the test of time. You can look in the literature. We have a wonderful clinical education website that we can forward to you. I promise you, if you have insomnia, it will cure your insomnia before you go to bed, because it's verbose, but it's very, very important. You know, things of like pulse wave pressures that come from ABIs, and the ABI itself in the 6th and 7th decade of life can actually predict patients that are going to have mild cognitive impairment and may go on to Alzheimer's dementia from a vascular standpoint. So very important to measure the ABI. We overlay that test with 2 other tests. Pseudomotor testing is, for some of you that experience it today, you put your palms of your hands and the soles of your feet on a glass plate and a small electrical current is emitted. Some people will feel it's like a TENS unit. And what that does is it causes you to sweat. There are 200,000 sweat glands at the bottom of the feet. And we measure the sweat response both in amplitude, what the voltage is, and then over time, how long does it take you to sweat? And if there's a breakage in either one of those, we know that there's small blood vessel disease present. We know that there's microneuropathic processes present and microangiopathic processes. Now, here's the wonderful thing. Some patients will have some neuropathy and some won't, but they'll have changes. And so we're able to identify in the clinical sense early on from a detection standpoint. And then finally, the autonomic nervous system. This is really where endothelial dysfunction becomes a major player. You know, we were at another clinic today, an endocrine clinic, and we're talking about the importance in our diabetic population of identifying cardiac autonomic neuropathy. Things that you and I take for granted, standing up, maintaining our blood pressure, not getting dizzy, not falling down when we bend over in terms of our blood pressure dropping. Diabetics in particular have a very difficult time maintaining their blood pressure if they've got cardiac autonomic neuropathy. They've got gastroparesis. It's a no-brainer that they have that. And the American Diabetes Association recognizes it as it's so important as to recommend and make it as a standard of care to autonomic nervous system test their diabetic population at least once per year. But it goes beyond that, right? We are going to take the patient, we'll stand them up, we'll make them Valsalva, and we'll see what happens to their heart rate variability. And depending on what happens to their heart rate variability, we can glean a great deal of data from that, whether or not the patient may be at risk for sleep apnea, whether or not they're not at risk for cardiac autonomic neuropathy. And all of these things are very treatable. And so I will tell you, that from a patient standpoint, right, we have big wins and we have small wins, and then we have really big wins. I'll tell you about a patient very quickly that came to my practice. I had taken care of him years ago, lost him to follow-up over the COVID pandemic. Diabetic, came to me, his last A1C was 6.3. I scanned my chart, it was 6.7, 6.8, 6.4, 6.3. LDL was 80. Blood pressure was well controlled on losartan. And so he hadn't had a test in a number of years. And we did a test and it was grossly abnormal from his previous one 5 years ago, grossly abnormal. And so based on the algorithm that's been authored at Pulse and part of my clinical team, we're able to tell if someone has structural heart disease, left atrial enlargement, left ventricular hypertrophy, heart failure with preserved ejection fraction, etc. And it was markedly abnormal. So the algorithm recommended echo. Went to echo, had local hypokinesis, 25%. Went to cath and had a quadruple bypass a week after having our test. Completely asymptomatic. Now those are big wins in the sense that it saved his life. The bigger wins are the patients that we take that have early small blood vessel disease and we stop it in its tracks. Right? It's not enough to know that they have hypertension, but we can treat this both from a pharmaceutical sense and a nutraceutical sense. And obviously, through lifestyle modifications. I always say two things to patients. If you're smoking, you should stop. And if you're not exercising, you should start. Those are the two great forgivers. I mean, smoking, as you all know, is a significant risk factor for coronary artery disease. Exercise, I've seen it time and time again, in even patients that are morbidly obese, BMIs north of 38 to 40. If they're exercising, their endothelial dysfunction goes down, because when you exercise, you're promoting vascular neogenesis, you're promoting nitric oxide, and so it's very important. That is just a little schematic of the machine. Some of you saw today. It's a very small footprint. You don't need a lot of space to do the test, so that's important from a space standpoint. More important to you, who qualifies for the test? We have a screening questionnaire, so if they answer yes to any of these questions, one single yes will trigger a medical necessity. Obviously, the top three I've spoken about, those are the low-hanging fruits, so to speak. But any type of those questions, chronic kidney disease, heart disease, nicotine use, numbness in their fingers or hands, feet, collagen vascular disease, I see a plethora of mixed connective tissue disease, autoimmune disease. Those are all major players in the inflammatory arena, and those are all qualifiers. One of the most important things I can impress upon you, cancer, incredible inflammatory marker. Patients that have cancer tend to develop heart disease. In fact, we worked early on a few years ago for a short time with the Susan B. Komen Foundation. And one of the things that we found through literature searches and through our work with them is that women that survive breast cancer are more likely to die from heart disease than a recurrence of their breast cancer. That to me gave me, I mean, it woke me up. So that's an actual fact in literature. And so that's how important it is to identify inflammatory reactions. Just really quickly, as we end up here, it's a very easy footprint. We employ our own medical assistant, and patients get the screening questionnaire. You will enter a order into the chart, and then our medical technician does the test, and then it will give you a results, and then you'll go over the results with the patient. That's what it looks like today. So it's a little bit verbose on the right side, lots of green, lots of yellows, lots of red. Obviously, green is good, yellow borderline, red not so good, but all of those markers are a report card for both you and for the patient for improvement. And so things like lifestyle modifications, pharmaceuticals that are afterload reduction agents in the forms of ACEs or ARBs, nutraceuticals. I use a lot of nitric oxide derivatives. I'm more of a functional medicine guy, but things like L-arginine, which is an essential amino acid that we produce, they will help relax the vascular bed. I like to tell people endothelial dysfunction was like the woodpecker in my house when I was in residency in Atlanta, Georgia. Thought it was really cute. And I see her home pecking every day, just a little thing, peck, 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 until 2.5 weeks later it was gone. And then I went up into my attic and I actually pecked a hole in and then nested in my attic, and I had baby woodpeckers. That's what hypertension, high cholesterol, diabetes, smoking, it's just pecking away at our vascular endothelium. And I always say it's death by 1,000 paper cuts. And so we really have to be very diligent about looking for that. So that's what it looks like today. You have a macrovascular status for those of you that can't see it, an EKG assessment, endothelial function status. We are in the middle of the transition with that summary sheet, so it'll be more modifiable. We're going to shrink it to about 6 boxes, and you'll have a key to interpret it. More importantly, either myself or one of my clinical team members will go over test results. So what we usually have people do is order tests for a week or so, and then we'll get on a Zoom call, and then we'll go over those test results to make sure that everybody's educated. You have access to myself and my clinical team, so it should never be a question about, oh, I don't understand how to present the results. Our job, my job, what we're seeing the clinical team is to make sure that you understand how to present the results to the patient in a manner that will allow them to take better care of themselves. So it's non-invasive. Those are the billable diagnostic codes. I can tell you, most of the time, the EKG is a 3-lead EKG. It probably doesn't get paid, but we bill it anyway. Same thing with pulse oximetry. Those are smaller codes. The three large ones, ankle brachial index, that's 2 units. The autonomic function test is 1 unit, and skin test is 1 unit. In my experience, and we have a complete billing department with a revenue cycle manager that will go through this with you. They'll look at your patient population, and they'll actually be able to tell you who qualifies, who has deductibles the day of, who owes what if they're going to have the test. So it's very, very helpful. I'm in Connecticut, and I will say the only insurance that I've encountered in the last 5 years that will not pay for a test for us is Blue Cross Federal. I have no idea why. They just think they just will not pay for it. Regular Blue Cross pays for it. Medicare pays for it, obviously Medicaid as well. But Blue Cross is the only one that I've run to in the state of Connecticut that won't pay for it. But those are your diagnostic codes. And then finally, thinking about somebody, from your standpoint, from a larger practice standpoint, there's the chance for, or the opportunity for downstream revenue. I will say that based on our algorithm, we definitely detect silent heart disease earlier than most practices do because we're looking for it. And so we obviously order echoes to do that, stress testing, and refer that out. Arterial Dopplers for lower extremities, for claudication, etc. We see a lot of sleep apnea. I'm sure you all do too, right? And it was kind of like the vitamin D phenomenon years ago. Nobody was vitamin D deficient until everybody was vitamin D deficient, right? It was just like it just exploded on the scene. And sleep apnea, I've become much better at diagnosing, mainly because I use this testing in my office, and I'm looking for it, right? So any patient that's hypogonadic gets a workup, at least a screening questionnaire from a sleep apnea standpoint. And what we're trying to do from a microvascular disease standpoint is to preserve healthy microvascular tissue so it doesn't propagate upstream or downstream to macrovascular disease. So I'm going to stop there because I know I said a lot, and I'll open it for questions. If any of you have any questions, I'll be happy to entertain those, or any questions about the process and how we do it.
So based on the test results, it will guide us on what the next test to perform.
Correct, yes. Yeah, the question was based on the test results. Based on the test results, you'll get a summary sheet with recommendations for next testing, obviously if they're clinically appropriate. So it's fairly simple from the standpoint that there are some that are just given. So if you detect, carotid disease, definitely I can tell you we don't miss the mark on carotid ultrasounding, especially in the older population. The real big thing is patients that we seemingly think are okay, like the one that I spoke about earlier that are vasculopaths. Those are the ones that we're trying to determine if there's vagal dystonia in diabetes, right? Because it carries about a 30% mortality from sudden cardiac death. And we've all been part of that equation from a standpoint where people unfortunately do poorly because we didn't know, right? We're treating importantly, we're treating according to the numbers. We've got great processes, but people are still falling through the cracks.
Another question. Let's say they're on an antihypertensive, they're on a statin. Blood pressure in the office is good, LDL is near normal. Why would you do this test?
Yeah, so it's a great question. So the question was, they're on a statin, good control cholesterol wise, blood pressure is well controlled in the office. And why would we do this test if we knew that they're a vasculopath, right? And I think we talked about this maybe before. Maybe the key is, they're a vasculopath. I know they're a vasculopath, but I want to know if they've got structural heart disease that I haven't seen yet, because that changes my algorithm and thinking.
And that will better test like microvascular, you're saying?
100%. Yeah. So if they've got endothelial dysfunction, you could have them on all the afterload reduction in the world. Something's not going on, or something's not going right. So those patients I'll put on remote care monitoring and check their blood pressures as an outpatient daily. I'll add some nutraceuticals to help dilate their vascular bed, but there's something that we're missing, right? We only get 15 minutes at most, sometimes 20 minutes with patients, right?
We're lucky.
And they come in like kids going to Santa Claus. Have you been good this year? Of course Santa have been good because they want their gift, right? And how many times have you had a patient come and go, I quit smoking? And they're great, well, when did you quit smoking? And they're like, well, yesterday, because I'm coming to see you today. And it's just to make a point, right? Because we only get to see them from a short period of time. So in my mind, I want to take the best care I can of patients, hitting all my guidelines from a number standpoint, but I also want to know if they've got silent endothelial dysfunction, because I know from studies, especially with first responders overall, 75% develop heart disease from the catecholamines, or 75% have heart and have hypertension and heart disease. We know that, and that's from endothelial dysfunction. We also know that endothelial dysfunction is a precursor to hypertension, which is a precursor to coronary heart disease. So if we have somebody that's got endothelial dysfunction and it's happening in their small blood vessels, but it hasn't happened in their large blood vessels yet, better to stop it in its tracks in the small blood vessels. And you can do that through lifestyle modification, through nutraceuticals, through pharmaceuticals, and then repeat the test and show to the patient. I mean, just exercise. Oh my goodness, walking 3 times a week, 20 minutes a day, out of breath walking, right? I can't talk to your partner walking. Will prolong your life, quality of life by 3 years. There's numerous studies that show that. Just walking, it's free. For those that can walk, that don't have knee problems or hip problems, right? It's like, why wouldn't you do that? And patients are always concerned, right? I always say, you're healthy until you're not. And patients start to pay attention when they're not. And I personally experienced that. And so when things go awry, you do anything to go back up the clock. And so we're trying to give them the opportunity to take care of their small blood vessel disease before it's, because now we know there's a way to measure that. Any other questions?
Doc, I'm sorry, I came in late. What's the average test time?
20 minutes. So I didn't. So you didn't come in late. I didn't say that. Okay. Yeah. So average test time is 20 minutes. So from soup to nuts, from starting taking your shoes and socks off, non-invasive. They just have to take their shoes and socks off for their feet and obviously their hands. And our desire, we're really good at, and Sam can speak to this, we're really good at putting, our medical system does all of it, so it doesn't really add any extra time to you. Because I'm a busy internist and, Lord knows, we can't lose 25 seconds, right? 25 seconds times 30 patients is a significant amount of, right? Yeah, it's painful, right? Everybody gets it. You're waiting for the patient that you just finished your 9 o'clock patient at 8:59 and you're 9:15 still not there yet, and you're waiting, there goes my schedule, right? So we've all been down that road. So we aim not to add any extra stress or extra time.
Guys, we're going live with this tomorrow. Okay, and I think this is a great talk, because I think as physicians, what we're worried about is, who do we screen? And then what do we do with this information? How do we interpret it? It's a new test for us. We don't, and having you guys available for the first few weeks to help us interpret these results and how do we manage these people is going to be key. And then we need to decide, I think, on how do we screen, because, you know, I think you guys kind of screen everybody. And that might be a lot for us to give, you guys looked at this, right? It's got a copy.
I get from what I saw today.
We've got so much, our patients, when they check in, there's a freesia pad that just hits them with the depression scale and this and that. I mean, if we had a whole nother one of these on everybody, they're gonna freak out. They're already bitching about all the freesia questions, right? So I don't know if we have to talk amongst us, and do we zero in on just certain people?
And how many offices are we doing this? The two?
Two locations, but we can do this at all our we can tease people out of all of our locations and send them to these two locations.
You're thinking 2 or 3 per hour, right? The most.
We're scheduling
20
every
minutes.
30 minutes.
But when you're looking at the criteria, I mean, 60% more for you, Mike, because you're an internist.
Yeah. I mean,
Probably 80% of your patients qualify if only you need one yes
Correct, yeah.
on here.
Would you repeat a test?
I'm sorry?
Would you repeat it?
Yeah, insurance, yeah, absolutely. I repeat it, absolutely.
Twice in a
So,
year, you said.
yeah, insurances will pay, most insurances will pay up to 3 per year. We usually take
3 per year?
Yeah, we'll pay 3 per
If you
year.
make some changes, you want to see if there's
100%, yeah,
improvement?
yeah, and I've even changed,
Also,
you know,
we'll do it again, even short of a year.
oh my God, yeah, I will do something like for people that are really bad, I'll make implementation and then I'll bring them back actually in 6 weeks. And just to show them, and I have no problem as long as I document a plan.
Education.
Yeah, right, as long as I document a plan and I'll show them the improvement. That's where it really gets exciting, right? Because now you've got bad and now maybe it's mediocre, but it's better. And so that's positive reinforcement for the patient. And let's face it, patients are worried about their heart. Nobody wants it in their brains. And so, in their teeth and their eyes, and I don't know what order it is, but I've seen many patients come in. Like I saw a patient the other day, and I know she owes me money, and I'm a businessman, right? I'm an entrepreneur, I'm in business for myself, and I know she owes me something like $420. And I'm like, God, Carla, you look great. She's like, yeah, it's the Botox. So I just said, how much did you spend on that Botox, Carla? She said, so it wasn't that bad. It was $520. And inside I'm cringing. I'm like, God, you look great, right? So people will pay for stuff that they want and they'll pay for their health. Right, but they don't want to get sick, and when they get sick, then it's not that it's too late, but now you have to back up the truck and you have to re-educate. So we just try to prevent them from that happening. And again, our team will certainly tell you if there's a deductible, what the cost will be to the patient, which is very, very helpful.
Is there an age for this or just?
Yeah, so great questions. There an age for this. I'm an internist. I see people all the way from 17 to 104 right now in my practice. So generally speaking, I reserve it for 30s and 40s, but if they're diabetic, I'll screen if they're 21 because of the American Diabetes Association. That's a standard of care. But if you have a reason, like if you've got a hypertensive who's 30, absolutely needs to be looked at because that blood pressure issue is not going away.
And can I ask with those two other, I know what an ABI is, but what is?
Yeah, the ABI pseudomotor test is a test where the patient put their hands on a glass plate and it's a small electrical current that goes into their feet. And that simulates sweat. I can really get nitty gritty with the physiology. Chris has heard it 1,000 times. I kind of like, I love that. It's just, but it has to do with acetylcholine and postsynaptic junction. Nitric oxide gets produced in the sweat.
Measuring.
We're measuring sweat response. Yeah, amplitude of sweat response in time. And then the autonomic nervous system is a series of movement maneuvers, including bearing down, which it tries to mimic the sympathetic and parasympathetic nervous system. And measures small blood vessels.
No, I know that. So you ask them to bear down.
Yeah, measures blood pressure response, and more importantly, there's about 4 to 6 heart rate variability markers that we look at to make sure. And heart rate variability, it's just simple, right? If you and I are running up the hill, we have a stroke volume, heart rate equals stroke volume, or cardiac output equals stroke volume times heart rate. We come back down, I'm nice to you, you run back up the hill, but now I've got a 50-pound weight check down. And so my system has just changed dramatically. So I've got to have good adaptability in the heart rate variability to produce more cardiac output with a higher heart rate and stroke volume. If I don't, there's a problem with my sympathetic nervous system. So that's how it measures that.
What about renounce? So like the pseudomotor, do you see any variability? I know you mentioned connective tissues didn't have a greater incidence of some of these things, but the underlying issue with Reynolds with that. is-
Yeah, so it's pretty flexible. So right now, we'll definitely have changes in the pseudomotor, and usually it's just pseudomotor. For connective tissue disease alone, it's just usually pseudomotor that's abnormal. So I can tell you, I can diagnose somebody, like if I have somebody with mixed connective tissue disease, right, we used to call it psoriatic arthritis, then we call it blue Reiter syndrome initially. So if you've got psoriatic arthritis, you're gonna have changes with your pseudomotor, but Raynaud's won't make the test abnormal, won't make the test abnormal, they just have an abnormal sweat response.
Right, so I mean, I can interpret.
How do I interpret that?
Yeah.
From a Raynaud's phenomenon? Raynaud's will only have, if it's just a truly healthy patient, Raynaud's will just have their pseudomotor in their hands, usually is the only thing that's abnormal. Oh, it's not working again. Okay, so it's just, so we just the pseudomotor function is normal, their autonomic nervous system test is normal. So they strictly don't have small blood vessel disease. So those are things when you get one like that,
Yeah.
I'll guide you through those.
Yeah.
But the newer summary sheet will guide you through.
What, how it responds, you can tell it, I mean.
Yeah,
Okay.
no, I can listen. I've
Yeah, I
seen,
just didn't know if that would, because obviously when you have someone who's in vasospasm,
That one.
Yeah.
I would think that would,
Go back to.
that would kind of throw the test off, I guess. is what
Right.
I'm saying.
right, it does sort of test. It should be abnormal, but it will. So just the bottom section will be red in the hands and green in the other two. So I've done this in my life's work. I've probably seen close to 100,000 tests.
Yeah.
So it's easy to make connections when you start to see some of the data that comes
No,
through.
we just didn't know if, if they didn't have an official diagnosis, if somehow that threw it off where they would get a bad read or something.
I've never tested anybody with, haven't tested anybody with Sjogren's yet, so I can't tell you about that. Or scleroderma. But those two I don't know about, but I guess I'm gonna get back to self testing them and find out.
Test,
Yeah.
if she's positive.
Any other questions?
Oh, you gotta catch a flight.
No, I'm good. I'm okay. I'll just go a little fast. No, I'm just kidding. I just want to make sure that everybody, the big thing for me, honestly, I love what I do and I love doing this because I love taking care of patients. But more than that, I want to make sure that as you are starting to order that you feel comfortable. The biggest thing for me, just my portion of it is to make sure that you feel comfortable presenting to the patient. So that's what myself and my.
That's what we're gonna do, so we appreciate
Yeah,
it.
and we'll hold your hand all the way through.
Yeah.
You know, we'll treat you like a fifth grader if that's, like my kids always that come in, my son's a physical therapist, and he says terms that I think I should know. Like, Phil, I'm not a physical therapist. So you gotta back the truck up and let me know what you're talking about. Yeah, so great. So word track, Sam just said, how would you explain this? So I always tell patients, listen, we have a wonderful test that can tell me if we're on the right track with your medications, right? We know that we're really good at looking at large blood vessel disease in our patients, and that's why you're under statin or under antihypertensive. What we're not good at is looking at the blood vessels that make up the larger network, kind of like all the small back roads that make it up into the highway. So I want to look at that. Now, if you're having a test because you sort of yes on one of those things, the likelihood, and this is important, I always tell them the likelihood that you're going to have an abnormal test result is very high. That shouldn't be concerning to you. We want to identify this early so that we can treat it and change the pathway. So I prepare them that they're probably going to see some sort of abnormality, which when it comes back, they'll say, was there something wrong with that? I go, there was, but I expected it, and this is how we're going to treat it. So I think it's really good to set expectations. Very rarely, I have a very sick population, and very inner city, so very rarely do I get something that's normal. And I saw a couple of normals today, which was awesome, but when I get a normal one, I'm like, oh my God. It's kind of cool to know. And most of the time, the ones that are grossly normal, patients are exercising and they're not smoking, they're doing the right things, the things that are easy to do, but are even easier not to do. Right, well, I appreciate your time, everybody. Thank you so much. I know this is a long day for Monday for you. So I appreciate your time and look forward to seeing you guys on Zoom calls and whatever we can do to help you through the process. Just let us know.
Thanks so much.
My pleasure.
All right, so just as a reminder, we go quote unquote live tomorrow with ordering so that it's fresh in our minds. The first test will be 9/29. Sorry, I got this afternoon. So we'll order that. I'll have the neurologist kind of speak to, once we make the decision on how we're gonna hand out the forms here tonight. Then we'll start to work them through the practice and, we'll be able to schedule them at checkout.
Process?
Yep.
All right, workflow. So Janessa and I have gone back and forth, and the most seamless process to us seems to be when you identify a patient that could benefit from this test, you can let them know about the test and that they have to complete this questionnaire. You can print out the questionnaire yourself or just mark it on the encounter,
Still
and one of the NAs will print it out and have the patient complete it. At which point you will have to return, see if there were any yeses. If they were, you drop down the order and ask the patient to schedule at checkout. If they're testing at the same location, the front desk will try to walk them back, see if it's a good time for them to test today. If they are testing it,
Checkout sees this on the clipboard.
They'll
There'll
know
be
to
no
schedule.
schedule post.
correct. And they'll schedule it at one of two locations, 30-minute slots, so it's a 30-minute test. It is a 20-minute test, as they said, but as Sam explained it, I did one myself today. As Sam explained it, they allow the MA for the setup, the cleanup, et cetera, in between each test. Now, there's two things. We will have to scan this into our chart to make sure that we're not leaving it.
My biggest worry is he's not getting afforded.
Correct.
Yeah, let's,
Vanessa does have it typed up, we'll send it up, but we should talk to everyone about it to make sure it's gonna
Yeah,
work.
there's a lot of people missing from this meeting.
we're recording.
We be talking about it as throughout the day, as the day's going on, you guys are gonna report around the offices.
Yeah, I'll make my
Don't
way
forget
around.
to think about multiple calls, or your, any of your patients, all of them, like, I know Mike's been thinking about it, because he's involved in this. I just a little bit.
So we'll need to add the process and start passing around that we're walking.
Yeah.
So let the clinicians know and.
Maybe a little stack of already printed out on the.
Yeah,
It won't go into present.
It's printed out.
and from a operations perspective, we'll have to print it out twice. So once for the patient to complete the questionnaire and you identify whether they qualify for the test, the front
You
desk
see
will
what I'm
have to
doing?
scan it in, so there's no loss of that questionnaire. They don't have to do it again on the day of testing. But they will have to print it out, check-in will print it out on the day of, because pulse for pulse at that point will identify, because prior authorization is done ahead of time. So they'll identify exactly how much that patient, whether applied to deductible or what it is. However,
It's still frozen.
they will not, I mean, they'll notify the patient, but they will not bill the patient, correct, Jenna?
Correct. Wait, I'm sorry. Restate it in case I missed something.
They, prior auth is done before the test, that's why there's a line at the bottom that identifies what the financial responsibility is. And knows whether it'll go towards their deductible or not. Any other charges after that, that may arise from insurance, E4P will not bill them further, other than what's signed off on this sheet.
How much they go for, how much we. So what does the patient get billed, like this question?
Do you see it? I do. I'm
Yeah.
sorry. I don't have it right in front of me right
Yeah,
now, but I
in
do.
front of me. I know I have a whole workout.
Because I assume there's a split with the company, right? So they.
Correct.
bill
We,
them
mhm.
X amount of dollars, but we get. For X amount of dollars, I'd like to know, I need a refresher in my brain.
I don't have it in
I
front of me.
can't remember. Just so all the docs know, because this money goes directly into your budget, almost like you didn't each year. This isn't an ancillary that goes off to some ancillary partner that you look at. So, and if you order this test, make sure the power is strong, you know what I'm saying?
Where are the offices?
Which location? At Washington and
Sterling,
Sterling.
To start.
to start, yeah.
What's the price? What do they charge?
That's what I'm trying to look up right now, because I'm curious what the actual cost of the test is, and then what's our cut on it. What goes into my bucket every time I order one of these. How much?
No, this is just the questionnaire that the
No,
patients are
I
gonna,
don't generally know if she's looking at it.
if there's a, so
Sorry, you didn't commit it to my bike.
I'm gonna go through it since everyone's back. So you're gonna, if you identify a patient that can benefit from the study because of other, conditions they may have or be susceptible to, you will let them know about this test and give them this questionnaire, or you can mark it on your encounter and your MA can print it out for them. The patient will complete this form, at which point you will have to go back and identify whether there were any yeses. If they were, and the patient qualifies for the P4P pulse per pulse test, then you will order it in EMR. It'll just be a drop down like everything else we do. UDS or anything like that. And you will let them know to schedule a test at checkout. If we are testing at that location, then the front desk will try to squeeze them in if it's, if the patient has an additional half an hour. If not, they'll be scheduled for a half an hour test. It is a 20-minute test, but we allow 10 minutes for them to get set up and cleaned up and everything. And the front desk will scan this into the chart, at which point Principal Person will do their prior authorization, and when that patient returns for the testing, this form will be handed back. The amount of financial responsibility will be put on there. Patient will sign consent and they'll be tested. Yes, they do have ability that can do that in a moment.
So to qualify though, it was one yes?
One yes, any one of those questions. If it's all
Okay, that-
90% of my fees.
That's everybody.
Yeah, IBS.
Okay, so it's have this.
Yeah.
You get one, and, yeah.
I know.
Pelvic pain, I mean,
And
90%
then
of
I
my
think
patients.
with the slide, if we had COVID-19, that's like everybody. Did you see one of the slides?
Yeah.
Really? I thought he was putting up the screening thing, but I was sick.
I noticed that.
Said COVID.
It did say at the bottom of the last one of the slide I saw.
Which one?
If they have COVID-19.
I think it even said, have you had or have you been exposed to? Yeah, it did. But that's why I said,
That's 100%
because, I mean, the one, right? Do you feel dizzy or lightheaded? I mean, with 20-year-olds, I have that feel that.
Sorry, I fall.
But I mean, that's why I'm like, so, can I, because you want to do something, is this something else I can do to maybe help reassure them? You know what I'm saying?
Yeah.
Even from that standpoint.
Well, I had a question about how far back do we ask for the screening questions? Because I know he had that list, but I'm thinking about, the women that I end up seeing and they had severe preeclampsia, which is directly correlated to an increased risk of cardiovascular disease later in life. Are they on that list? Is the studies there for that? The same way that I recheck, A1Cs on those who had gestational diabetes 20, 30 years before? I mean, that's going to
That's a
be a
great
lot
question.
of my patient base.
That's a great question. I wish you would have asked that when he was here. I bet you it's a yes.
I was going to call him because when I'm listening in, some of the things he said were a little muffled on my end. So I do have more questions, and maybe I'll compile a list and call or email him.
Regulatory response qualifies. If we could look at one of them, yeah. And no age. No.
You mentioned, are any cardiologists doing this? Discuss, just curious.
Across the country, yes, in the couple meetings that we had with them prior to the focus group.
They brought a cardiologist.
We brought a cardiologist to us, yeah, forget it. And then MHP is currently doing this. I went live a couple of months ago. I believe they're some of the cardiologists from MHP are doing it as well. I don't know everybody's exact. So, average net revenue per patient. Oh, I lost the
How much?
average net revenue per patient based on, qualifying test in the state of Michigan is $118. That's after their service fee. And, Medicare's national average is 207.
That's what we get after their
Right,
fee.
after their fee, yeah. One test fee is 75. One test fee is 130, and the whole package per test is 200. Like if you only did an ABI for some reason, that's how it breaks down.
So it's gonna be about $200.
$200 per test for the service fee. And then the, average net revenue is 180.
Sounds like that lifespan. Offered.
So 118. What's the number? So, let's say it again, you go 200.
No, we bill higher than that. I don't have our master in front of me right now, I'm sorry. We bill higher than that. The net revenue is 118, so it's somewhere between 450 and 6. Julie?
I'm going to have to, well, it's acceptable. Yeah, they are.
I asked if for any reason they've ever had to stop the test midway because of a reaction patients were having or anything like that. They mentioned tealing of the hands every now and then, but it's never had to stop the test. The only test that they've ever had to stop is the blood pressure cuff on the calf for elderly patients who can't tolerate the pressure. However, they can still do the ABI with just the one ankle, one upper arm. So they still are able to complete the test in the
Since we are rolling this out, will we be able to track patients' responsibility financially?
Yeah, so it actually gets billed through us. They're just
So once we get some numbers. we'll
supporting us
see
in the
that.
billing, but everything will happen in all scripts. We'll be able to provide reports and track. Other questions on that? And this, like Nora said, continue to watch your emails for further updates from Janessa.
I just want it to roll out. I don't know if it'd be like allergy testing.
Right, and that's why we wanted to,
Failure.
you know, they even, Janessa, truth be told, Janessa even asked and said, are you sure it's okay to start? Because they, from a staffing perspective, they couldn't start till the 29th, and she was like, we meet with them on the 15th, are they gonna be able to, you know, or is that too much time in between for it to, and it's allowed, once you have this education. And I said, well, that's why we should start ordering it now, so then we build up a schedule, so when they start, they're busy. And when we did the allergy thing, we met, and then it took a couple more months, and then they started, and so that's why we wanted.
Those guys had a bad attitude too, so it
Also
wasn't just us, it was. Yeah,
Also that,
yeah.
so, as long as we can start ordering them, then we can really get them. And then also, if there are gaps, like if you have a patient, like that is in the location at Sterling or Washington, that can be tested same day, they can do that also. They have the ability to get the authorization moved. And it's no additional impact on our staff, with the exception of checking the patient in. They do all of the authorization and work with Tracy on the billing and that.
The doctor has to have to be in the office, and
Yes.
We moved the last time on the schedule.
No, guys, but I got it.
Washington and Franklin.
Those are. We haven't defined an exact period of time. No, we're just gonna have something with the.
And we just
Just saying 7%.
There's no minimum expectation either, right? So
Just so everyone.
that makes sense.
5 days a week, that will be business. For Sterling, we'll have you for around, but if they're pretty. You don't need any salary for it. Yeah. No, that's what I'm saying. They're bringing their part in the machine and they want, yeah, they don't need to store anything. Was that? Mhm. Yeah, and they are okay with moving like Monday being more than Tuesday.
I'm curious, how do you get what's to? If the room availability, we resigned to the because we saw the X-ray. Before we actually had it in all locations, the numbers, we had X-ray in location.
Sterling's always a good centralized location
Yeah.
to beta test everything.
Patient volume.
Correct. Correct. Right. But remember, even when we moved out to San Francisco, numbers went up.
And initially, the idea was Shelby, but some days it's very difficult with Shelby from a
Bills.
room availability perspective. And so the idea is that because Shelby and Washington are so close to each other, that patients will be able to go up there for that test. And Washington has a, we'll call it quote unquote procedure room that was not being used. So that's a static room that won't impact there. And then Sterling, depending on the day, they can move till our construction is complete. And then once construction is complete, in the lab, then, they'll be able to use the for some. But if we, as we start to and see more frequency in ordering or more interest, we can work with them to add more locations. They were willing to do all of them, but we want to start small, right?
Where's the job? I know Janessa has screenshot. It's under Myriad and Gene site, right along the lines of those. No, they weren't. We just worked on it.